Alright, chapter 24 is going to be psychiatric emergency. Recognition of behaviors that pose a risk to the advanced DMT, the patient, and or others. Basic assessment and management of basic principles of mental health system, acute psychosis, suicidal risk, and agitated delirium. Psychological or behavioral crisis might be the result of a medical condition, mental illnesses, mind-altering substances, or stress itself. So, perfectly healthy people may have some symptoms and signs of mental illness from time to time. The most common misconception about mental illness is that you are feeling bad or depressed. You must be sick. So, some reasons that people may be depressed is a divorce, loss of a job, possibility of death of a relative or a friend. So sadness is a normal reaction to a crisis situation. If sadness becomes long-term, it may be an indication of a behavioral problem. Many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. Only a small percentage of people with mental health problems fall into these categories. Although you cannot determine what has caused a person's crisis, you may be able to predict whether the person will become violent. All right, behavioral is what you can see of a person's response to the environment. Responses can be obvious or unclear. Most of the time, people respond to the environment in reasonable ways. At times, stress is so great that the normal ways of adjusting do not work. A person's behavior is likely to change, even if only temporary. New behavior may not be appropriate or normal. Disagreement over what behavior is. There is some disagreement over what behavior is normal. So no clear ideal or model. It tends to vary by cultural or ethnic groups. Classified as what society accepts. Abnormal behavior is anything that deviates from society's norms or expectations. Tends to interfere with a person's well-being and ability to function and may be harmful to an individual or group. A behavioral crisis or emergency is any reaction to events that interferes with activities or of daily living, or ADL as they have it acronym here, or has become unacceptable to the patient, family, or the community. For example, in the interruption of a daily routine tends to recur on a regular basis, the behavior is also considered a mental health problem. It is then a pattern rather than an isolated incident. Isolated short-term incidents are normal. If an abnormal or disturbing pattern or behavior lasts for at least a month, it is a matter of concern from a mental health standpoint. Chronic depression is a medical diagnosis of a persistent feeling of sadness, despair, and disencouragement. A person who is no longer able to respond appropriately to the environment may be having a psychological or psychiatric emergency. The patient may show agitation or violence, or then they may become a threat to himself, herself, or others. Psychiatric emergencies are more serious than typical behavioral emergencies. An immediate threat to the person involved or to others in the immediate area should be considered a psychiatric emergency. The magnitude of mental health problems. According to the National Institute of Mental Health, at one time or another, 1 in 5 Americans have shown some type of mental disorder. An illness or psychological or behavioral symptoms may be the result in impaired function. It can be caused by social, psychological, genetic, physical, chemical, biological disturbances. Some common causes of behavioral alterations are listed in the table. All right, pathophysiology of abnormal behavior. Factors that can produce behavioral emergency, abnormal behavior, or mental statuses can be sudden grief, emotional conflicts, psychological problems, sudden illnesses, and recent trauma. Recent drug or alcohol intoxication, diseases of the brain such as Alzheimer's disease, hypoglycemia, hypoxia, and exposure to excessive heat or cold. Organic causes of behavior emergencies. Organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain tissue. Causes can include sudden illness, recent trauma to the head, seizure disorders, drugs, and alcohol intoxication, overdose, or withdrawal. Functional disorders. Etiology cannot be traced to an obvious change in the actual structure or physiology of the brain itself. Examples of psychiatric disorders include schizophrenia, anxiety conditions, and depression. Psychiatric signs and symptoms. They reflect the body's attempt to maintain its balance in the face of physical stress. Grouped according to the systems they affect. These psychological functions involve our consciousness, thought, affect, memory, orientation, and perception. They can affect consciousness, motor activity, speech, thinking, mood, and affect, memory, orientation, perception, and intelligence. So, patient assessment, you need to do a good thing. Size up with these patients also. Assessment of the environment can give clues to the patient condition or cause of the emergency. Determine your mechanism of injury or nature of illness. Primary survey for a general impression. Determine how the patient is responding to the environment in which they're present to. Does this patient's behavior seem to be typical or normal given the circumstances? So try to respect for the patient's territory and limit touching without permission. Assess the pupils. A behavior crisis puts tremendous stress on the person's coping mechanism. The person is incapable of responding reasonably to the demands of the environment, or they may be temporarily has an acute illness, or it may be a longer lived has a complex chronic mental illness. The patient's perception of reality may be compromised. So limit the number of people around the patient. Sometimes the patient just needs to be brought out of the environment that they're staying in or that they're involved in. Sometimes that's the best thing for these patients, just get out of a situation that they're in. So try to separate the patient from the bystanders or family. Always watch for these patients with for signs of agitation and aggression. A potentially violent patient make up only a small percentage of those undergoing a behavioral psychiatric crisis. So assess the level of danger using their history. Posture, is the patient sitting or standing, or are they walking, pacing back and forth in the same spot? Some of my patients I've seen, they're doing circles sometimes. Assess the scene. Is the patient holding or potential lethal objects? Do they have access to them? Can they get to them quickly? Sometimes getting these patients into an environment in which you know and you can control is better for you also. Vocal activity. What kind of speech is the patient using? Also look at their physical activity. Are these patients hollering at something or somebody? Are they hallucinating, talking to somebody that's not really there? Have they potentially gone back into the past? Are they agitated because you're there? And some of these patients know what the next step's fixing to be and don't want you there. So watch their physical activity. Are they being violent towards others? Are they being violent towards people that they know and they trust? So that can lead you to know that they're probably going to be violent towards you. All right, investigate the chief complaint. Focus on the questions on the immediate problem. Use therapeutic interviewing techniques. Sometimes if we can approach these patients as, we're here to help you. Let us help. You help us help you sometimes. Limit physical contact. Some of these patients don't want you to do anything to them. They just want you to ride them to the facility. So avoid using any threatening action, statements, or questions. Approach the patient slowly and purposefully. Evaluate the potential for suicide or harm to others. A patient who has a detailed plan or access to the means to complete it, they're likely to carry out the plan itself. They've thought about this for a long time. So a lot of times they're not scared, to do it even in front of responders. Utilize the surroundings. Utilize family, friends, and observers. May be a great help in answering the patient's history questions. Sometimes they may, tend to, disrupt the scene. Maybe that patient only trusts one person. Ask everybody else to leave, and use that one person. So reflective listening, advise repeating back to the patient what they have said, encourage them to expand on their thoughts. Active listening is being supportive and empathetic. Allow time for answers and limit interruption. And sometimes the patient experiences behavior psychiatric emergency will not respond to any of your questions. So note facial expressions, pulse rate, respirations, tears, sweating, and blushing, and look at the patient's eyes. A lot of times if the patient looks away from you, they're really, something deep or it is bothering them what you're saying, and that you are speaking some kind of truth to them. So when trying to determine the etiology of the patient's consider 4 major areas of possible contributors. So is the patient's central nervous system functioning properly? What is the general condition of the patient's environment, and is the patient dressed appropriately and clean? Is there any evidence of substance abuse? Does the patient see strange things? Is everything distorted? Or do you smell alcohol in the patient's breath? Or do you have a combination of all of these? Are there any psychogenic circumstances, symptoms, or illnesses involved? So it may be mental rather than physical factors. Document the patient's intellectual function. Is the patient oriented, memory intact, able to concentrate, and use appropriate judgment? Does the patient have disordered thoughts, delusions, hallucinations, unusual worries or fears, and express suicidal, homicidal threat? So note the patient's speech pattern content, and is the speech garbled unintelligible? What's the patient's mood like? How is the patient's hygiene? Is the patient's motor activity normal? In your secondary assessment, look for signs of organic causes of the patient's behavior, change of vital signs. Look for the fever. The patient might have indications of increased ICP. They might have had a trauma and they're able to walk around with it. And now they've got an increased ICP and it's causing them to act like a psychiatric patient. So you may have a trauma patient on top of a medical problem. Assess skin temperature and moisture, or any problem with tattoos or scars. Inspect the head for violence of trauma or evidence of trauma. Check the pupils for size, equality, and reaction to light. You could have an toxic ingestion or intracranial pressure. Note any unusual odors on the patient's breath, such as poisons, alcohol, ketones, and diabetic ketoacidosis. While examining the extremities, look for the needle track marks, tremors, or unilateral weakness or loss of sensation. So you get your vital signs. So evaluate those and use your monitoring device. So interventions, reassessment is routinely performed during transport, and monitor your vital signs for changes. All right, give the receiving hospital an advance warning. Report whether restraints will be required. They could also have caused them to call for additional resources to come down to the emergency department itself. Document thoroughly and carefully, and if restraints were used, say what type and why they were used. You want to make sure that when you document with restraints, make sure that you have a good medical reason why you use those restraints. Make sure they have good peripheral motor sensory prior to and afterwards. So you don't want to cause more harm than what's already been done. But you also want to take care of yourself and your partner. All right. Maintain your safety for your patient and yourself. Place the patient on the stretcher with the straps in place. Remain with the patient at all times, and avoid challenging the patient's personal space and being judgmental. So try to remain calm with these patients. Try to remain with them at all times. So sometimes these patients want to go into other rooms and shut the door. We don't want that. We want to be able to stay within the eyeballs of these patients, being able to see them at all times. Even if they try to go to the restroom, if you have somebody there of the same sex, you may have to send them in there with them, just so that you know that patient's not in there trying to do something that's not good for them. All right, acute psychosis is a state of illusion in which a patient is out of touch with reality. So the line between reality and fantasy is blurred. It causes psychotic episodes. So the use of mind-altering substances, intense stress, delusional disorders to get schizophrenia. Sometimes these episodes last for a brief period, or they may last for a lifetime. So disorganization, disorientation are always in which various conditions such as schizophrenia and organic brain syndromes may present themselves. Schizophrenia is a complex disorder that is not easily defined or easily treated. Typically, onset occurs in early adulthood, with symptoms becoming more prominent over time. Some things that can cause or contribute to this disorder is brain damage, genetic, psychological, and social influence. So some symptoms may be delusions, hallucinations, a lack of interest and pleasure, and erratic speech. So patients are usually incoherent and rambling in their speech. A thorough examination of the patient is rarely possible. So you might want to use the COAST map, mnemonic consciousness, orientation, activity, speech, thought, and memory. So, evaluate each one of these to see where these patients are at. So also affecting mood and perception. Usually method of reasoning whether a patient are unlikely to be infected. Use your uncomfortable feelings to help make a tentative diagnosis. Directions should be simple, consistent, and firm, and non-pharmacological techniques should be adopted. So, be precise in what you need these patients to do and tell them, what they need to do so that you can help them. Try not to use any kind of drugs with these patients, because a lot of times, the receiving facility needs to do a baseline blood draw. So, but sometimes you may have to use restraint, but if you have to, call for a paramedic backup, and they might use an anti-anxiety or a sedative to help slow these patients down. All right, suicide depression is the most significant factor that contributes to suicide. So a lot of these patients become depressed over time. They get to the point that they can no longer deal with it. So anytime you encounter an emotionally depressed patient, consider the possibility of suicide. It is a common misconception that people who threaten suicide ever commit it. So a suicide threat or attempt is a cry for help. Threatening suicide is an indication that someone is in a crisis that he or she cannot handle alone. So immediate intervention is necessary. Some warning signs: does the patient having an air of tearfulness, sadness, deep despair, or hopelessness that suggests depression? Does the patient avoid eye contact, speak slowly or haltingly, and project a sense of vacancy? Does the patient seem to be unable to talk about the future, and ask the patient whether he or she has vacation plans? Is there any suggestions of suicide, or does the patient have any specific plans relating to death? Additional risk factors for suicide: unsafe objects in the patient's hands or nearby, unsafe environment, evidence of self-destruction behavior, imminent threat to the patient or others, underlying medical problem. A suicidal patient may be homicidal as well. All right. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is characterized by restlessness or irregular physical activity. Although patients experiencing delirium are generally not dangerous, if they exhibit agitation behavior, they might be struck out irrationally. Symptoms include hyperactivity, irrational behavior within attentiveness, or vivid hallucinations. So, hallucinations are erroneous perceptions of reality. So the patient may see you as a threat. If you can safely approach the patient, be calm, supportive, and empathetic. So approach the patient safely. Do not leave the patient unattended unless the situation becomes unsafe. Use careful interviewing to assess the patient, trying to indirectly determine the patient's orientation, memory, concentration, judgment. Try to determine what the patient is thinking. Pay attention to the patient's ability to communicate clearly, and pay attention to the patient's apparent stress and personal hygiene. So if you determine that the patient requires restraints because he or she is a threat to himself or herself or to others, make sure you have adequate, well-trained personnel available to help you before approaching the patient. The patient appears to be experiencing an overdose. Take all medication bottles or illegal substances with you to the medical facility. So mood disorders among the most prevalent mental disorders. So up to 21% of the population will experience mood disorder. The changes the change in effect are accompanied by other symptoms which cause a major disturbance in a person's ability to function. So manic behavior is one of the most striking psychiatric conditions. Abnormally exaggerated happiness, joy, or fury with hyperactivity and insomnia. Patients are awake and alert, are easily distracted. Flight of ideas or delusions are granular, make it difficult to focus on one thing. Racing thoughts or tangible thinking. The memory may be distorted by underlying delusions and psychotic symptoms such as hallucinations. So high probability of getting themselves into trouble when one sort. Depression is the leading cause of disability in people between the age of 15 and 44 years old. Affects women more frequently than men and may occur at any age. Identified by a sad expression, bouts of crying, and listless or apathetic behavior. Signs and symptoms of depression may be for days, then not for a period of at least 2 years. It may be chronic form of depression known as dysmic disorder. So use the gas pipes for diagnostic features. Guilt, appetite is abnormal, sleep disturbance, pain attention, interest, psychomotor and abnormalities can be increased or slowed, energy, suicidal thoughts. All right, treating neurotic disorders comes at a substantial price. Anxiety disorders are mental disorders in which the dominant moods are fear and apprehension. So, general anxiety disorders, the patient worries about everything for no particular reason. Phobic disorders involve an unreasonable fear, apprehension, or dread of a specific situation or thing. Panic disorders characterized by sudden and unusual and unexpected and overwhelming feelings of fear, dread, and accompanied by a variety of symptoms. Women are more likely to be affected by this condition, and it can identify a stressful event that preceded their first attack. Consequences of autonomic nervous system discharge and hyperventilation. Symptoms usually peak in intensity within about 10 minutes and last around an hour altogether. Steps to control these situations is separate the patient from the panicked bystanders, provide a calm environment, help the patient to regain control, give the patient symptoms a name, and reassure that the patient is safe. Any patient experiencing a panic attack should be fully evaluated at the hospital. Hyperventilation is best managed initially by pushing the patient to slow their respirations until they regain control. Some medical and legal considerations are more complicated when a patient undergoing a behavioral crisis or psychiatric emergency. Legal problems are reduced when the patient consents to care. Gaining the patient's confidence is crucial. Mental incapacity can take many forms or responses such as hypoxia, drugs, or hypoglycemia, temporary but severe stress, and depression. Once you determine that a patient has impaired mental capacity, you must decide whether he or she requires immediate emergency care. A patient in a mentally unstable condition may resist your attempt to provide care. Do not leave the patient alone. This may expose you to civil action of abandonment or negligence. Request law enforcement personnel to handle the patient, and request law enforcement to help the patient if the patient resists treatment. and then threatens AEMTs or else. So implied consent is assumed with a patient who is not mentally competent or to grant consent. In a situation that is not immediately life-threatening, emergency medical care or transportation may be delayed until the proper consent is obtained. Contact medical patrol, follow your local protocols when in doubt, and consent matters are not always clear-cut in psychiatric emergencies. So patients do have that right to refuse care. Most states have legal statutes regarding emergency care of mentally ill or drug-impaired patients. Law enforcement personnel can place such a person in protective custody so that emergency care can be provided, or medical direction may order the transport of the patient against his or her will. A competent adult that has the right to refuse treatment, even in life-saving care, is involved. In psychiatric cases, a court of law will probably consider your action to be providing life-saving care to be appropriate, particularly if you have a reasonable belief that the patient will harm himself, herself, or others without your intervention. A patient in any way impaired, whether by mental illness, medical condition, or intoxication, may not be considered competent, and they do tend to refuse treatment or transport. So when in doubt, consult your supervisor, police, and medical direction, and always err on the side of treatment and transport. These patients can be sometimes hard to cohort into going to the hospital, and you're going to have to use your judgment as to whether they are incompetent to the point that they no longer are competent to refuse care. These cases can be very difficult to assess sometimes. So, you need to consult with law enforcement, consult with medical control, and get a consensus amongst everybody. So restraints must be ordered by a physician, unless you need to follow your local policies and protocols. Legal action can involve charges of assault, battery, false imprisonment, and violation of civil rights. Use restraint not only to protect yourself from others or bodily harm, to prevent the patient from causing injury to himself or herself. You may use only reasonable force as necessary to control the patient. And different courts define this differently, so always consult medical control or contact law enforcement personnel for help before restraining the patient. Okay? So a patient who is restrained by law enforcement personnel is in their custody. If they're using their cuffs, they're in their custody. So always try to transport this third patient without restraints if possible. You need at least 4 people, and make sure you discuss your plan of action before you do it, so that everyone's on the same page. Use the minimum force necessary, so avoid physical contact that may cause injury to the patient. Secure the patient's extremities with approved equipment, and treat the patient with dignity and respect. Never place the patient face down, and check for circulation in all restrained extremities frequently. Document the reason for restraint and the technique that was used, and be careful for a combative patient to suddenly calm and cooperative. So I don't ever try to take restraints off of a patient that's already been restrained. So they will play games with you and play with your mind sometimes. And as soon as you start unrestraining, they're going to come back and be ready to fight again. So post-traumatic stress disorders is returning to combat patterns. PTSD can occur after exposure to or injury from a traumatic event. It is estimated that 78% of the general population will experience signs of PTSD at some point in their lives. So some signs and symptoms: feeling of helplessness, anxiety, anger, and fear, avoiding things that remind them of the trauma, nervous system arousal that continues and is not easily suppressed, heart rate increases, pupils dilate, systolic blood pressure increases, senses are sharpened, and mental acuity is heightened. And people with PTSD can relive the traumatic event through intrusive thoughts, nightmares, or even flashbacks. Recent traumatic events may also be triggered on memories and create a reflex reaction of preparing for their worst. Dissociative PTSD occurs when the person attempts to find an escape from constant internal distress or a particular disturbing event. Guilt, shame, paranoia, hostility, and depression. So, when treating the combat veteran with PTSD, try to eliminate excess noise. Veterans are much more likely to harm themselves or try to harm themselves. Combat veterans may develop heart disease earlier than expected. Given their age, they have a higher incidence of type 2 diabetes and sustain a loss of brain gray matter. They're also at risk for high cholesterol and hypertension, higher incidence of traumatic brain injury sustained from trauma secondary to the explosion on an improvised explosive device. TBI may be undiagnosed because of its manifestations are similar to the symptoms of PTSD, or because the patient downplays the symptoms. So, with treating a combat vet with PTSD, try to eliminate excess noise. Do not touch anything to the veteran without an explanation. These appearances can be a trigger for combat vets, and a unique level of understanding, compassion, and specialized attention is required. Take time to establish the history of this patient and listen to his or her concerns. Approach this patient with sensitivity and respect, and be careful how you phrase your questions. Just remember what these vets are coming back from. Also, I'm going to say this now rather than later. Do not be surprised with PTSD and first responders also in the public safety community. Even if you approach somebody that in the public safety community, PTSD may be living with them also. And that's the end of this chapter. So, low socioeconomic status, unstable family structure, and inability to keep a steady job, substance abuse, depression, and functional order as far as physical activity. Tattoos might give you a clue as to what they've been involved in. Substance abuse may give you a clue that why they're trying to act the way they are. They may be having an adverse reaction to that, to that medication. So, follow your local protocol. Take these patients to a facility that can offer them the services that they need, and can offer it to them in a way that is as quick as possible. Some facilities do not have psychiatric specialties, within their reach. So you may have to transport these patients to a different kind of facility or a distance.